Thank you very much. I'd like to thank all of you for this kind invitation in these wonderful islands, Greek islands, and I'd like also to thank you particularly Professor Nikos Dargonakis because it was really a fantastic welcome here. And this is really a nice topic also because when I started my work in functional urology, uh, we had the first experience when we didn't call underactive bladder, but just urinary retention, non-obstructive, and using intravesical electrostimulation. And that was great for us because it gave us the impression to be, be in, in the head to recovery the bladder control. So first of all, I have these are my disclosure, and also the ICS office recommended me to show the benefit to be ICS member, but I think that all of you knew. What about the chooser under activity? We find the first definition based on urodynamic examination just in 2002 that define the chooser under activity as a contraction of reduced strength and duration resulting in prolonged blood emptying and failure of achieve a complete blood emptying. But if you have a OAB definition at the beginning of this millennium, just in 2015 we have the definition, the clinical definition of UB, of underactive bladder, and this was defined as a symptom complex that are suggestive of the chooser underactivity, and usually they have a prolonged urination and with or without sensation of incomplete blood emptying, and also with hesitancy and a reduced sensation feeling a slow stream. So if you go to analyze what change in definition, in the urodynamic definition, you see that the impaired contractility, now the terminology say that is a reduced strength, and also the hypotonic bladder has reduced duration, but also was introduced the concept of reduced velocity of contraction, and as well that many of these kind of patients had an abnormal perception of bladder volume. And this is what is changed in the urodynamic evaluation. But if you look at clinical situation symptoms, we have no specific symptoms for underactive bladder because there is an overlap with overactive bladder and also with the bladder obstruction. And here you can see that only in 9% of men we have only storage dysfunction, and only in 22% of women who have only storage problem. So if you look about epidemiology, we have no clear data because as you can see, there are most is represented in men with 40% of men with DU and only 13% of DU in women. And we have a different range of incidence of also in elderly and women. And in the last paper by Hosman, as you can see, there is really a wide range of incidence of DU, and it is ranged from 9 to 48% in men, and from 12 to 45% in women. So the data is really more approximately. And if you have a look also, I see that there was also a nice presentation also if I didn't understand a lot, only the slide about aging. But when you look at aging people, they have usually not only isolated DU, but usually they had DO and DU together. It was in the whole terminology, was the chooser hyperactivity with impaired contractility. And this is an interesting observation, and this is, I think, the basis of the hypothesis of Chancellery. And what he noted is that usually they have both, and he suggests that maybe is a multifactorial causes for the U. Is aging, endothelial dysfunction, atherosclerosis, hypertension, diabetes, and bladder outlet expression. So these can, at first stage, with for oxidative stress, you can have the chooser overactivity. But during time, as last phase, if you don't treat in time, it go to become the chooser underactivity. This means that usually we have a detrusopathy, that the chooser doesn't work, and at first it works too much, and then it fails to work. And based on this clinical observation, they also had some basic research on rats, and they tried to induce atherosclerosis using cholesterol, and also vascular damage just with occlusive pelvic arterial, and also endothelial dysfunction. And what they find in rats was that in the early stage they induce overactive bladder, but during time the dysfunction turned in bladder underactivity. So this time they had the hypothesis that just when the first early stage in people that are to have problem with underactive bladder is to have overactive symptoms, and during time it became underactive symptom is the last stage of a damage of the chooser function. If you will look about symptoms, about clinical diagnosis, in this study, Game and al. Observed what are, if there are specific signs for the chooser underactivity in men and also in women. And at least what they find was that the only symptoms that are specific are just enuresis and at the same time stress incontinence. I don't know if it was really stress incontinence or maybe it was just overflow incontinence, but they define it as stress incontinence. So this lead to have a new consultation to modify a new proposal of UB definition. And what they inserted in the new definition was that usually people with underactive bladder have a palpable bladder, but I think only if the patient is in complete retention. They refer straining to void, enuresis, and or stress incontinence. And this is just a definition of this year. Oh, sorry. Oh. Oh, what happened? Oh, I am going back, sorry. So, if you look and about urodynamic measure, also about mathematical calculation, index occlusion testing, you have at the end of the day no specific sign also if we do urodynamic evaluation. And this is a limit of our investigation. And in this study, they tried also to evaluate if there are any parameter for men that can be correlated with the diffuser underactivity, but was not find any parameter to correlate. The only parameter that was correlated was in human that present a p-det Qmax under 30, and also a bladder volume estimation criteria. And this was the only one that can be applied for women with DU. So there is another study just to have a non-invasive diagnosis, and there was the study of the bladder wall. And randomizers and all demonstrated in this study that if we find the diffuser thickness that is less than 1.223 and a bladder capacity more than 440, this is a combination that allows us to diagnose DU. So about pathophysiology, we know that we can have some impact, some mechanism at suprapontine level in the brain. In this case, we have a failure of integration or processing of the voiding function. If you have an efferent impact on sacral or peripheric innervation, in this case, we have an impaired activation of the diffuser. And if you have an impact in the afferent pathway or peripheral efferents, we have early termination of voiding reflex. And last but not least, if you have some damage just in the muscle, we have a loss of intrinsic capacity. And this is a very important aspect when we try to recover bladder voiding. So about pathophysiology, we have neurologic injury, and we have a different pathology, stroke, spinal cord, particularly when sacral innervation is interested. But we have also some idiopathic, and in this case, usually we don't know what is the reason. And also we have some iatrogenic, such as when we have some pelvic surgery, radical pelvic surgery, such as prostatectomy in the men or radical hysterectomy in human. And we can have also a myogenic cause, such as in people, in patients with diabetes, or some effect of pharmacotherapy in people, in patients with comorbidity, especially in elderly people. So these authors tried to understand if there was a different expression of DU related with different pathology, disease. So it takes people with a cardiovascular manifestation, people with a cardiac risk factor, neurologic patient, idiopathic etiology, but he didn't find any difference in the DU expression. This means that it is a multifactorial problem, not just related with one disease. And about aging and DU, also there was some study related to animal, and what they demonstrated was that there is usually an upregulation of beta adrenergic receptor and also an upregulation of purogenic receptor. And also was demonstrated that maybe there is a reduced Cy-Faber afferent, so they have some problem with the sensation of maturation, and some also altered degrees of PACAP that can induce also some problem about sensory innervation. But in this study of Osman, recent study of Osman and Chappell, the clinical ureodynamic data do not provide strong evidence to support the assertion that the diffuser contractile function decline with normal aging. So there are also some interesting study about the structural change in the bladder wall, and what they find was that by aging there is a decrease of bladder smooth muscle, and also there are a caveolin number and morphology with associated selective alteration in caveolin expression, and this is what they find. But also, if it was demonstrated that in patients with DU, there are a high number of damaged cell profile, but there is no correlation between age and damage of the cell. So this is something that is still unclear. And if we look about some ultrastructural finding correlated with DUA, we find a lot of modification in the bladder wall, but we don't know if this modification come before DU or are just the effect of DU. So we need more trials to understand if what is the starting point of this problem. And what we see also was some study about biomarkers and DU. So what we found was that the PGA2 and also the brain-derived nerve growth factor was significantly higher than in control group in DU patient, and the patients that present higher PGA2 and BDNF level have more opportunity to have a recovery of the diffusor function. This means that maybe there are some neurotransmitter that after can help us to have to reach a recovery of bladder function and of the diffusor contractility. So at the moment, we have no really effective pharmacotherapy. You know that in the last 20 years, you use some parasympathetic agents such as beta-nickel, but you know also that there are some really side effects, and also intravesical PGA2 and some opioid receptor antagonists. But we use also some drugs such as alpha blocker, baclofen to decrease outlet resistance, but we have at the moment no evidence to use in our clinical practice. So now there is a lot of research about new drugs, and working on bombesin receptor, or the effect of PG3 or ATP and NO, and also in CGRP. But these are just studies that are going on, and we have at the moment no definitive results. And some other drugs that we tried to use in this kind of patient were dopamine, nerve growth factor, and also muscarine receptor N2 and aggregin proteins, but we have only some results in acute phase and nothing else. So what we found also as published data usually are just treatment to decrease the resistance of bladder outlet. And there is some paper about botulinum toxin, but we know that the first paper by the Fowler group in the Fowler syndrome, where we have a bladder diffusor under activity, but due to hypertone of the bladder of the pelvic floor. And in this study, she demonstrated that botulinum toxin doesn't work. But there was a new paper that showed good results in 32 patients after injection of the distal sphincter. But another paper that was published in 2016 by Young demonstrated that it doesn't work really, and it works only if still you have a bladder contraction, otherwise it doesn't work. And also about, I know that there is another presentation about what to do when we have the user under activity and also BO. And what you can expect is that if we have the UI, we have to have a good counseling with our patient because the outcome will be with a poorer IPSS and also a poorer improvement of Qmax. And this is also a way to study with the urodynamic, also to avoid sometime surgery for inappropriate patients. And also, if we compare some kind of treatment using laser, what in this study was demonstrated that HOLEP usually improve much more the voiding pattern than 2AP. But I think that this is just because maybe you have much better disobstruction of your patient. And in this study, also with bladder neck incision, these authors demonstrate that usually they can have an improvement of bladder voiding, but they use to have a cutoff value of a preoperative study that they must have the Chusor contraction at least of 45 centimeters of water. Some old technique also was presented, such as reduction cystoplast, or new technique like latissimus dorsi detrusor myoplasty, but we have only 2 papers without follow-up. So I think that these are just something to be studied. They need a good trial before that you can say that is a solution for our patient. So if you go really in the real life, what you can do in our practice is, first of all, sometimes it's good to put a catheter in dual catheter just to avoid some wall damage if you have overdistension, and also to avoid if there is any problem for the upper urinary tract. And then try to have intermittent catheterization for our patients. And the important is not just have intermittent catheterization, but is also to have a good management of intermittent catheterization, avoiding overdistension, because overdistension of the bladder can induce myogenic damage, and with problem of fibrosis, and so you can lose completely the detrusor function. So this is, I think, one of the first published paper by Madesbacher using intravesical stimulation to recover bladder voiding. We used the Catona technique, and in 80 we showed really fantastic results. Our group studied also the effect of intravesical electrostimulation. And as you know, intravesical electrostimulation needs to be repeated during time, every year or maybe every 2 years, after they shift from intravesical to sacral neuromodulation. What we found is that usually people that are responders to intravesical stimulation, they are good responders also to sacral neuromodulation. Instead of people that are non-responders to IVES, after they don't respond as well to sacral neuromodulation. So we don't know exactly the mechanism, how can work the sacral neuromodulation. What we think is that we have inhibition of sympathetic effect and also improvement of parasympathetic action. And this can improve the bladder voiding. In my mind is also that maybe this kind of patient have a new sensation from the pelvic floor, and they experience a best control of the bladder voiding. Here are some results about sacral neuromodulation and the urinary retention. And you see also if you have a lot of patients and with a high rate of success, but these are just in the early stage. In the long-term results, we have this review by Van Kerrebroek, and he showed that he had at 5 years 78% with the urinary retention with good results. And usually people that have good results at 1 year, they maintain results during time. And we have also here a longest follow-up. It is about 14 years. And also here what we found that he usually have a good result during time about 62%. And in the Fowler syndrome, we have better results than in humans that have urinary retention but are no Fowler syndrome. We have also some data after post-hysterectomy with voiding dysfunction. Is a small sample, only 13 humans, but they report good results in this kind of patient. About sacral neuromodulation, also in our study, we reported data about spinal cord injury patients with incomplete lesion. And we had some good results also in the long term. And one predictive sign was if they have a recovery of sensation of the bladder feeling in the time. But this is related only to really select patient. So sometimes we don't have the result that we hope, and we have to go back to intermittent catheterization. And sometimes, if intermittent catheterization is not possible to be performed because it's too old, because you have no a third party, a good caregiver, you have to go back to indwelling catheter, and I think is not. We are not happy with this final conclusion, but you have not to forget our patient if our attempts to recover bladder are without success. So I think that maybe my friend Chara is not happy with this, but this is the reality, and I'd like to thank him for the nice lecture he had in ICS in Florence and the whole Greek group. And I think that we had really success with the highest number of delegates, high number of abstract, and I think that this was not Italian success, but European success, that we are really good organizer about functional urology. So the invitation is also to the next meeting that will be in Philadelphia next year. Thank you very much for your kind attention.
Thank you very much for this very interesting lecture. I think τυπικά σε ομιλίες state of the art δεν κάνουμε ερωτήσεις, αλλά εάν κάποιος έχει κάτι να ρωτήσει, ωραία. Thank you again. Thank you, κύριε Σπυρόπουλε.
Acceptance of our invitation, and offer him two small, very small presents from the Naval Museum of Chania. Just to remember an old painting of the ancient city of Chania, and two small, yes, two small cups here.
Oh,
Thank you. Thank you. Thank you again. Thank you.